Welcome to the Multiple Sclerosis Series Part 2, presented by Northwestern University Feinberg School of Medicine at NeuroSeries Live. You are tuned in to the live session, The Potential Role of Biomarkers in Diagnosing and Managing MS with Dr. Suhail Dib-Jalbat. My name is Dr. Michelle Fabian, and I'm Assistant Professor of Neurology at Icahn School of Medicine at Mount Sinai. Today's session is a live interactive program that allows us to take questions in real time throughout this presentation. I encourage you to send us your questions anytime during the program through the box in the lower left-hand side of your screen. I'd now like to introduce Dr. Dib-Jalbat, Professor and Chairman of the Department of Neurology at Robert Wood Johnson Medical School and Chief of the Neurology Service at the Robert Wood Johnson University Hospital. Dr. Dib-Jalbat has dedicated his career to multiple sclerosis research, as well as caring for those with MS. Welcome, Dr. Dib-Jalbat.
Thank you, Dr. Fabian, and good morning. What I would like to do in the next 30 minutes or so is to discuss the potential role of biomarkers in diagnosing and managing multiple sclerosis. This presentation consists of two segments. In the first segment, I would like to discuss the potential biomarkers we have to distinguish responders from non-responders to therapies in multiple sclerosis. And in the second segment, I would like to discuss how we can use biomarkers to look at adverse events with prolonged treatment for MS. It is imperative to understand the immunogenetic mechanisms of MS when you are taking on this issue of identifying biomarkers in multiple sclerosis. And as you know, there are both genetic and environmental factors involved in the pathogenesis of MS. On the screen, I've listed some of the known genetic factors. We know genes are important based on twin studies where the concordance rate of MS is about 25 to 30% in identical twins. In addition to that, a number of alleles have been identified to be associated with multiple sclerosis. The most known one is the HLA-DR2, which we call also DR beta 11501 in molecular terms. And I would like you to remember this allele because when we discuss biomarkers of glutaminyl acetate, I will be referring to it quite frequently. In addition to that, many other alleles have been associated with MS. And what's interesting about those is that most of them are linked to the immune system, particularly to T lymphocyte function, which underscores the importance of the immune system, in particularly lymphocytes, in the development of multiple sclerosis. On the right side of screen, you see some of the environmental factors implicated in MS. Among those are microbial agents, and at the present time, EBV seems to be quite interesting because it has been associated with the risk for MS as well as disease progression. We also know that a fair number of MS patients are deficient in vitamin D. We test for that, and we supplement patients with vitamin D if they are deficient. Smoking have also been associated with increased relapses and progression in multiple sclerosis. And this year, interesting data came out implicating a high salt diet in the progression of multiple sclerosis. So both the genetic and the environmental factors are important. They interact together to lead to immune dysregulation and subsequently onset or disease progression in MS. And understanding those factors may give us some clues and potentially biomarkers that would allow us to predict disease progression in MS. Now, when you're searching for a biomarker in multiple sclerosis, the biomarker has to be practical. It should be quantitative, objectively measured. It should be easy to do in an accessible tissue, preferably blood, maybe spinal fluid. It should be easy to measure in a practical assay. And most importantly, when tested during early treatment, it can predict the clinical response in the long term. And finally, it should have high sensitivity and specificity. As you know, there are now at least 8 approved drugs for multiple sclerosis that you see on your screen. The interferons, 3 of them, glitimirar acetate, natalizumab. We have 3 recent oral agents that we use now, fingolimod, teriflunomide, and BG12. I should say that the search for a biomarker has advanced significantly with the interferons and glitimirar acetate because they've been around for some time. Unfortunately, we do not have much in the way of biomarkers at the present time with the oral agents because they are relatively new. Now, there are 2 ways of looking at biomarkers in MS or searching for a biomarker in MS. One would be to use the powerful tools of genomics and proteomics in search for a molecule that is modulated by those therapies, and then see if that molecule bears some relationship to whether the patients do well or not on treatment. The other approach is a more focused approach based on the mechanisms of action of the drugs that we use in MS. So on this complicated slide you're looking at, I show the sites where those drugs work. Just to orient you, at the bottom of the screen, you see the peripheral circulation. The red bar in the middle of the screen is the blood-brain barrier, and at the top is the central nervous system. So briefly, we think that MS is caused by the invasion of inflammatory cells into the central nervous system through the blood-brain barrier. This involves pro-inflammatory Th1 cells, B cells, and Th17 cells that adhere to the blood-brain barrier, and then they pass through into the central nervous system where they initiate a cascade of inflammatory events involving attacks by immune cells on the neuroaxis as well as antibody-mediated immunopathology. So on this screen you see the interferons. They work by inhibiting Th1 cell function as well as by interfering with the migration of Th1 cells into the central nervous system. Glitimirar acetate, on the other hand, works by inducing regulatory T cells. Those are the blue cells that you see at the bottom of the screen. Among them are the Th2 cells, Th3 cells, FOXP3 positive cells. All these are regulatory T cells that are induced by some of the therapies used in MS. They also enter the central nervous system, produce anti-inflammatory cytokines like IL-10 and TGF-beta, and suppress inflammation within the central nervous system. You also see natalizumab there, or Tysabri. This is a monoclonal antibody that binds to VLA4 on T cells and B cells, and by doing so, it prevents the adhesion of those inflammatory cells to the blood-brain barrier, and therefore blocks cells from getting into the central nervous system. I also show there fingolimod, which is a sphingosine 1-phosphate receptor agonist. It modulates that receptor by internalizing it, and by doing so, the lymphocytes are trapped within the lymph nodes. They can no longer get into the circulation, and they cannot get into the central nervous system. Teriflunomide is a cytotoxic or cytostatic drug, and BG12, the most recently approved oral agent, is believed to be an immunomodulatory as well as a neuroprotective agent. Now, those 3 oral medications, fingolimod, teriflunomide, and BG12s, are relatively new, and therefore there isn't much in the way of biomarkers that we can discuss today. So I'm going to tell you about some of the work we've been doing with biomarkers of interferon beta. One of the most reliable tools to look at responders and non-responders to interferon beta is probably the MRI at the present